Hi everyone. Today we will be talking about health economics for prescribers. So this activity will be just like the de-prescribing activity, will be delivered as a blended learning. So you will have um, access to this presentation while you are in Minerva. In fact, if you are listening to this talk, it means that you are undergoing that blended learning activity. Just a brief description what we are going to do in today's presentation. It will give you an operational understanding of various definitions, terms about economic evaluation and how do we do economic evaluation in in healthcare. We will also um, go through with how do we decide on if one treatment is better in terms of economics than other treatment. And for that we are going to examine what the cost effectiveness plane is, what is the incremental cost effectiveness ratio, and terms like quality adjusted life years, so you will have some understanding of how you can study, read an economic paper or a report so that you can make sense of it and how you can use it then in your practice. So, like anything that has become a common public concept, economics also have a simplest side to it as well as the most complex side to it. Um, because whenever we have a scientific term or a phenomena that we apply in our daily life and it become part and parcel of society, then there is this common understanding of the phenomena, which is in most cases not incorrect. For example, when it comes to economics, we know that the phenomena is that it will be about cost, it will be about saving, or something like that. In its most academic terms, the economics is the sign which deal with the allocation of resources. We all know that we are living in a limited resource environment and we have choices that are basically unlimited or way more than the resources available. So that's why we need to allocate resources to specific choices. Otherwise, we won't be able to cover everything. And that's where the economics come in. When it comes to health economics, is usually the same principle applied in health context. For example, if you can see this um, a picture, like the image on the right hand side, um, I'm trying to see the, yes, I can get the cursor now. So as you can see, the health related economics will be, you will compare, you know various cancer treatment. For example, you can compare cancer with diabetes, you can compare asthma management with emergency treatment of asthma. So, like, managing asthma in community, in primary healthcare effectively to avoid um, hospital rated admission, or diagnosing cancer early. For example, this particular example is about diagnosing cancer early, and you can see that if you diagnose cancer early, you're going to get some benefit of treating it early, and then you have a cost of early diagnosis versus a cost of later diagnosis. And any study that will compare these two options can be an economic evaluation. Uh, this leads us to the basic of what economic evaluation is. So an economic evaluation cannot be non-comparative. Now it's easy to listen to it, but sometimes we struggle to see if there's a true comparator. So doing nothing is a comparator in clinical sense, it's also a comparator in academic research sense. But when it comes to the economic evaluation, doing nothing is not a true comparator. So when you're talking about a true economic evaluation, you cannot say that you're comparing this state of the art treatment with doing nothing, because the economics point of view is that there's always something being done. If you are even not doing anything, that includes some sort of cost, because not doing anything will it still include somebody assessing you as a doctor, so you are using some sort of resources. But when it comes to economic evaluation, you won't have a non-comparators, you always have a comparator. It's usually the standard of care that is the comparator, but it can be a new treatment, it can be a combination of treatment, it can be something which you would like to compare it with the treatment that you are evaluating. Um, so, in reality, you won't find that there is a non-comparator whenever it comes to a medicine, um, whenever it comes to a surgical procedure or something else. Um, so we always will have a comparator, and that's why when we look at the types of economic evaluation, you will always see that the definition depends upon a comparator. Now, in its simplest term, economic evaluation is nothing but a comparison of cost and benefit of individual treatment option or individual choices. So, at the end of your economic evaluation, in simplest term, you should have a value showing, okay, this treatment A is that much effective as per unit cost. So for each unit of cost, for each resource allocation, you are going to deliver some level of efficiency, some level of benefit. So for each benefit, you can say, okay, if we spend that much cost, we are going to get that much benefit, compared to treatment B, where we spend that much cost and we are going to get that much benefit. And then we compare both of these, and then we pick up the one that offer us best value, not necessarily cheapest cost, but best value means that is going to give us the best value for our cost or for our dollars or quids or pound invested. So the when it comes to the types of economic evaluation, we have four types. We have like let's describe it in a different way. So if you forget about that we have four type, let's assume that if we have a cost and a benefit evaluation, how things can go. So things can be same in terms of their effectiveness, so they can deliver the same benefit, but the cost that they are delivering the same benefit uh, against is different. So one is expensive, one is cheaper. In that case, it's very simple. So you basically need a cost minimization analysis. Two things, they are delivering same benefit to us. We are getting exactly what we want from them. One is costing us less. It's no brainer, not a huge calculation or mathematical equations needed there. You simply choose the cheapest one because the benefit are exactly the same. And that's why we call it cost minimization analysis, because it just simply minimize the cost. When it comes to the cost effectiveness analysis, there's the thing where we are comparing two treatment options. One is definitely better. It has proven to be better. It gives better efficiency. For example, a new drug, it is able to decrease hospital admission. Another new drug, it's able to increase the quality of life compared to the another treatment. So in summary, we know that the benefit are more from this particular option. All we need to know is how much extra cost we will be investing per unit of effectiveness. So what we need to know, we know it is better, we need to know how much better it is, and we also need to know if we invest the same amount of money, then like the same ratio of money in terms of the benefit, will the benefit exceeds? So let me explain it in simplest term again. The cost effectiveness analysis will differentiate between a treatment that may be expensive. For example, let's talk about very simple example. We all know that the new cancer drug can be given orally and can have very good quality of life, less side effects, and can easily be managed in outpatients compared to the old cancer drug that you need to give injectable chemo drug. You need to prepare them, you need to give them in certain way, you need to monitor patients, so you need to have patient in the hospital being monitored, closely monitored. You will have a lot of blood tests associated with it. So if the oral tablet option will cost more than the injectable cancer drug, which is an old drug, uh, we we need to know if the delivery of the treatment is also expensive. So you are not going to just compare the cost of the tablet versus cost of the injection. You are going to then compare the overall cost of giving that treatment as well. So even if you forget about the benefit, the important is that we need to look at the cost itself, and the cost need to be comparable. So whenever we talk about cost in cost effectiveness analysis, is the cost of giving the treatment and not just the purchasing cost of a particular medicine. We're going to discuss this a little bit more finer detail in next few slides. Cost benefit analysis is exactly like cost effectiveness analysis. There's no difference, and that's why it took more time in describing you the cost effectiveness analysis. So cost benefit analysis is exactly like a cost effectiveness analysis, except that any benefit that you are getting from the treatment, for example, decrease in a hospital stay, reduce emergency visit, um, reduce GP visit, better quality of life. All you need to do is you need to convert the benefit into a monetary value. So it needs to be either a pound or a dollar value, and the effectiveness, the whatever the effectiveness is, you just change it into dollar value. So it's basically cost in terms of dollar invested translated into the benefit in terms of dollar or in terms of pounds. So you convert the benefit into monetary value, it become cost benefit analysis. Cost utility analysis is again exactly the same as cost effectiveness analysis, except that the outcome, the benefit that you are measuring is not in dollar term, is not in effectiveness unit, for example, admissions, GP visit, emergency visit. Rather, the benefit is in terms of QALY, which is quality adjusted life year. We won't go into what QALY is right now. We just trying to cover, just assume QALY is something. So it's a utility measure. So QALY is the output that we are going to measure. So recapping these four type of analysis, again, simplest term. So either treatment is effective or treatment is not like either treatment is more effective or treatment is either similar or not more effective. So if treatment is similar or not more effective, is simple. You are going to go with cost minimization analysis, because all you need to do is which one is going to cost you more, is stick with that. Oh, sorry, which one is going to cost you less? My apologies. Stick with that. So you will go with the cheaper option because the benefits are same. Then the obvious second situation will be when the benefit are better. So when benefit are better, or the outcomes are better with one treatment compared to other treatment, Then you start working on non-cost minimization analysis. So first one is out of the picture because the benefits are greater, different, better. So now you need to compare the cost with the benefit. So if you are going to keep the benefit in its original form, for example, um, any outcome measure as admission to the hospital, admission to the emergency department, less frequent attack of asthma, secondary prevention, less secondary attack of heart attacks, um, no exacerbation or less exacerbation of heart failure. That is your effectiveness outcome. You keep it as it is. It's called cost effectiveness analysis. If you change your benefit or outcome into a dollar value, into a monetary value, then your analysis become cost benefit analysis. If you replace whatever the benefit it is and try to quantify them in quality adjusted life year, quality of life, then the analysis is going to get called cost effective, cost utility analysis. The stand-alone non-comparative analysis you're going to find here and there in books is called cost of illness analysis. Is basically when you try to find out how much diabetes is costing UK, how much asthma is costing UK. You do a cost of illness study. You just measure what is the cost being lost or wasted because of the illness in terms of productivity, in terms of lost wages, in terms of resource utilization. Is just a costing study. It's not a full economic evaluation. When it comes to economic evaluation, there are only the four that I've just explained you. Now, the reason I explain that much in detail is because you need to know why you're doing cost effectiveness analysis or why you're doing an economic analysis. And the reason you are doing an economic analysis because you have various treatment options to compare, and you need to have a very good understanding of what are the different types so that when you're reading about it and when you are applying the concept, then you know those concepts in reasonable details. It's important to understand that some concepts, some essential concept in health economics that become the part and parcel of every economic evaluation. So we are going to go one by one. So perspective in simplest term is who is paying for it. So whose point of view you are going to take. For example, if you're looking at NHS, because NHS is publicly funded, so when you are going to do any NHS based analysis, you are going to look at societal perspective because society is paying for it. People are paying for it. If you are looking at for an insurance system like US, you'll be going to do it from payer perspective because you want to see whether it is cost effective for a certain insurance body, certain HMOs, or certain state government who is basically funded in some public-private partnership. So in situations where a third party is paying but there's not a public third party, you go with the payer's perspective. If you're going in a private healthcare environment, you go with a patient's perspective. So for example, most of the surgical procedure, you also look at from the patient's perspective that whether patient will be willing to pay that much amount. Cost, in terms of cost, you have direct costs, you have indirect costs, you have opportunity costs, marginal cost. So there are different type of costs. We are going to discuss it later. Benefits, again, can be health benefit, can be quality of life gain, can be actual money saved. And as you can see, those cost effectiveness analysis, cost benefit analysis, and cost utility analysis, I explain you how these analyses are different because the benefits are measured differently. Now, sensitivity analysis and discounting are pure economic terms. We are going to discuss it in brief. It really doesn't apply to day-to-day cost effectiveness or pharmacoeconomics or health economics application in your daily practice. But it's good to know what sensitivity analysis is and what discounting is. So sensitivity, as the name suggests, um, you would like to see whatever analysis you have done, how sensitive that analysis is to different changes. So we all know that things happen in our day-to-day life that change the assumptions that we made about things. For example, the cost of petrol can go up and down, and the assumptions that we are making is that it will remain stable, but then something drastic can happen in the market which decreases or increases the supply of petrol, and that will increases or decreases the cost of your petrol. Same goes with the health intervention. For example, if big changes in economics happen, if the value of pound goes down or up, the things that we are importing or exporting can have different impact on the prices. So whenever we do economic analysis evaluation and we say, okay, this thing is cost effective compared to the other thing, we are making all the assumption because the cost can go up and down. The benefit may realize, you may realize there's some adverse effect that we didn't realize earlier on is happening with the medicine. So what sensitivity analysis does is it increases and decreases the value of different parameter in your economic evaluation. And if by decreasing or increasing the model remains stable or the benefit persists, it shows that the model that you're proposing or the benefit that you're realizing are more durable, more resistant to fluctuation, and this gives us some confidence if we are doing a sensitivity analysis in our economic evaluation. It gives us this confidence that we have some margin of error in our assumptions. They won't just become redundant the moment one particular aspect of the economics change. Discounting is when we discount the value of money. It's a very easy concept if you think about it. There's an inflation, there's also the devaluation of the money because money goes down. Money never increase in value, it always decrease in it buy less over time. So whenever you do economic evaluation that lasts at least more than a year, 2 years, 3 years, 5 years, it's important that you put a discounting to the amount of dollar invested. Again, we do this to demonstrate that it's a um, real value of the money in future. We also have depreciation of our assets. So if you are buying a machine and you are paying it over 5 years, then after 5 years you will need replacing of that. It will also cost much lesser in future. So if you're paying over time, so then you're not basically paying exactly the same amount that you are paying today. Um, and all those things are important to consider whenever you are working on bigger economic evaluation. As I told you, sensitivity analysis, discounting, and the last thing, which is modeling, is not as relevant to you guys, but it's important to know these concepts. So when you read a report, you don't feel completely confused about it. You know what these terms mean. Now, the modeling, the last complicated part, is whenever we do economic evaluation, we need to um, we need to model what's going to happen. For example, in its simplest form, uh, let's imagine because like when we look at the treatment, we look at the treatment when clinically we look at the treatment, we look at a very narrow angle. For example, a treatment is effective or not effective. Um, Somebody die or somebody lives. So it's usually binary option that we are looking at in simplest clinical routine. But in real life, it's not like that, because when you are going to try to quantify the benefit of any treatment, you will see that a patient may get the treatment, and some of them may get cured, but some of them may get relapse, and within relapse, some of them will become less symptomatic or not symptomatic, and some of them will become symptomatic. And if treatment fail, then there's a cost of that by you have to give another treatment. Even if that treatment has also a treatment option, then they will be either cured or fail. And even people who cured, not everybody will going to have side effects from the treatment, but a proportion of them will have. So with each medicine or each intervention or each treatment option or choice, you are going to have so many branches coming out of it, just like a tree. And that's why we call it decision tree. Same goes with another way of modeling, which called Markov modeling, and other technical models are available where they try to quantify what happens to patients in a given time, because not every patient is going to start from clean slate treatment A, you know, freshly diagnosed. What if you got somebody who got diagnosed 5 years ago, have tried so many other things, so they can enter your whole decision analysis in midway through the treatment cycle, and you need to quantify that. And in order for you to do that, you need to have a model that allows people to enter at any time. So whenever you see these complex models in papers, you'll realize that there's a logic for it and there's a reason for it. But again, as I told you, these things are just good to know. They are not relevant in everyday practice. So we are not going to go into further details of it. That's why I just spent some time here. We are going to look at the cost benefit in more detail. So, as I told you, cost can be of many types, uh, but you need to understand that in its broadest definition, in broadest classification, cost can be divided into direct, indirect, and opportunity cost. Now, uh, opportunity cost is the cost that you forego by the cost you incur by foregoing the opportunity of using it somewhere else. For example, if I'm going to invest 1 million in the manager of asthma in my CCG area, then I can't spend that million on, excuse me, any other option. I cannot spend it on diabetes. I cannot spend it on cancer. I cannot spend it on housing. I cannot spend on anything else because I've already spent that million into asthma. And that is the opportunity cost. So it's important for us to understand that we are aware of what opportunity cost is, and what is the importance of opportunity cost means that by letting go the opportunity cost, we are letting go an option. Now, when it comes to marginal cost, so direct cost and indirect cost, I'll explain it to later. But in simple term, direct cost is the cost which is directly associated with the delivery of the treatment. So anything that you do in terms of delivering the treatment is direct cost. Um, for example, the example that give you about injectable oncology medicines, that is direct cost, because cost of mixing it, cost of storing it because a refrigerated item, cost of mixing it in a safe manner so that the people who are mixing are not exposed to cancer, drug, or cytotoxic chemicals. Uh, that is part of the costing. Um, the cost of storing it after you have mixed it, the cost of storing it at ward, the cost of equipment used to administer that, all of that part of the direct cost. The indirect cost is for example, if a treatment require a carer to be present, or if a person is unable to drive to the treatment center and that person is relying on another person, a colleague, a friend, a family member to drive them, and they are losing their wages, they are finding all of that, you know, um, uh, impact on their life, their quality of life. That is the indirect cost, which is very seldom considered as indirect cost, because we usually um, put direct costs as a, so example is if the cost is required of somebody to be present, patient needs to have somebody else, then that should be included in the costing exercise. But that's a stretched example of indirect cost. Marginal cost is nothing except that remember we say that we need to find out what is the unit cost benefit. So how much benefit we are going to get per unit of cost. So we somehow need to uh, come up with a costing number that describe one unit of benefit. Otherwise, it will be a nightmare to compare two different treatment options. So we need to reduce it to the unit form. For example, and it depends on the unit itself. For example, I'll give you a simple example. So you can have a unit cost of one healthcare associated infection prevented. So that is one unit of benefit. You can have the unit cost of delivering 1 millimeter of mercury decrease in blood pressure achieved. You can do that. um, so you need to look at the outcome quali. So you need to have the unit cost of per quali gain. So one quality of life adjusted year gain, and how much money you need to gain one of that. You need to divide benefit in a way, you need to transform benefit in a way where you can then calculate a cost of achieving that particular benefit, so that when you're comparing it to something else, you can say, okay, let's say this drug decreases the emergency admissions to hospital per admission, that much is going to cost. So for example, if we buy this treatment is going to prevent, like, 5 admission in 100 patients. So basically it's only preventing, about 20.00 something. So what you need to do then, you need to calculate, because you can't just calculate the cost of treatment per patient. You are going to find out how many patients you have treated, so like number needed to treat. So you find out number needed to treat, so you treat 7 or 8 patients, and after treating 8 patients, you get the one benefit, so you get one hospital admission being avoided. So then you go back and calculate, okay, 10 patient is going to cost $100,000, and after spending $100,000, we are avoiding one admission, or is going to cost $10,000 or $5,000. So you you should not um, you should not get carried away by the cost per patient. You need to find out cost per benefit, and that's important. And that may be low or less. For example, it may be millimeter of mercury, maybe much less. Hospital admission provided may be huge. Life saved may be huge, depending upon whatever the outcome you're looking at. So the marginal cost is going to tell you exactly that one extra unit of your outcome or productivity that you are after. Now, things to consider in costing: the source of costings. So a lot of the time source of costings are published for NHS, they are available online. Excuse me. uh, you also need to find out if you are going to um, cost or is cost a charge or a price. For example, in some evaluations you would like to know what you will be costing it based on what is the price of that thing, because that may not be just the cost. It's um, it's cost plus any margin that you'd like to make on that activity, because you want to compare that this is what it is going to cost in real life with everybody's margin, everybody's um, contribution. This is what is going to cost us. So you need to think about that. You also need to think about if the cost of the treatment, like overall, what will be the cost of treatment? Um, what will be the cost of changing the way we do business? So, for example, some treatment won't just change the treatment, it will change the way the treatment is delivered, it will change the way the care is being delivered. So if there is cost on top of the treatment or cost on top of the intervention, you will need to think about that. You also need to think about if that intervention will start getting more cost that you never thought of before. For example, introducing of that particular intervention required ongoing training cost of your staff, is going to require some updates. Some software will keep getting updates, some newer version. Will the old version, old infrastructure will support itself or not? So a lot of this. Consider buying a smartphone. So a lot of us buy smartphone, don't even realize that it's not just the smartphone. It comes with for example, data plan. So if you are going to use something which is highly data intensive, you may be going to spend more on ongoing maintenance of that phone, because it just give you things that you never used to it and now you're using them, watching movies online and all of that. So you see, sometimes the intervention will have unintended consequences, but you need to think about it, that what are those issues that are end up having additional costs to the intervention itself. Now the benefits, in its broad term, benefit will vary, because benefit won't be exactly the same in every patient. So the nature of benefit will vary from intervention to intervention, and the variation within benefit are going to also vary. So if you are um, if you are implementing something, you need to first identify what are your benefits. So if it's cost benefit analysis, cost effectiveness analysis, or cost utility analysis, efficiencies, qualities versus money. um, you also need to know if you are getting an indirect impact. So your benefits are not direct benefit. For example, you are increasing the guidelines adherence. Now it should increase the good practice and it should give you the benefit of increasing practice, but you cannot quantify that from that design. So what you're doing to do, you're going to assume that you don't have to do everything. So what you can say, if your analysis says that I'm only looking at increasing the guideline adherence, and I know if I increase the guideline adherence, it works. So what you're going to say, you are only going to say that for um, each percentage increase in guideline adherence, that much how we will spend to increase the guideline adherence. Or you can see for each 5% increase, each 10% increase, because then you need to go into evidence and find out what proportion of benefit is realized in terms of what increase in guideline adherence you are after. If you are increasing the efficiencies in your service, for example, you are implementing a nurse clinic that is going to look at asthma patients. So asthma nurse, diabetic nurse, in that terms, you are increasing the efficiency. So what you want to know is in terms of benefit, what are the patient outcomes? So are you able to deliver the better patient outcomes as per your new service? If you are going to look at um, um, oral cancer treatment, same example, which is going to increase the efficiency. Yes, it's going to increase the efficiency because you can treat more patients. You don't have to have patients in the hospital. If you are increasing the guideline adherence as well as you are increasing the efficiency, for example, you have multiple outcome measure, then you are going to have different analysis within the big analysis. So you will going to assess those separately. Be mindful that you are not going to. So if you look at people have uh, um, assessed the guideline as well as efficiencies, and they're just talking about one big improvement, it's not a good economic evaluation. It's not a good economic science because you cannot just have an amalgamation of all the benefit joined together. So you need to have benefits separated. That's a good sign that it's not well thought economic evaluation. Um, Benefit single versus multiple observation is also important. And the reason I would like to discuss this is when it comes to looking at economical evaluation or when it comes to look at economic benefits, you need to look at where the source of data is. So if source of data is just single center in your clinic, in your state, just one study is not as respected. You need to see that if the benefit data or the even the as a matter of fact costing data is coming from well published sources. So for example, if you want to know whether the oral tablet are as good as for cancer treatment, you are better off going into meta-analysis of that oral tablet and look at multiple clinical trials that are showing the same benefit because um, a single study or single observation will have an inbuilt error. Whatever we measure, we have inherent errors in it. And if we only have one measurement, then we are basically relying on not so reliable source of data. But if we have multiple observation, we can spread out errors, and it means that we have much more confidence in our outcomes. Now, it is important to explain you guys what quality of life is, why we measure it, how we measure it, and like what is the big fuss about quality. So, this just a cartoon that remember the 20 extra years you agreed you added to your life through clean, healthy living. Well, these are them. So yeah, we know that these days because we are. Um, so the whole idea, as you can see from cartoon, is um, there is no point. Well, it's personal choices, but there is no point. There's no economical or health system-based logic in having a really poor quality of life, um, life prolongation. So you have, like, years where there's nothing. And it's really important in cases where we are dealing with those chronic diseases which have a lot of complications, and people have really miserable lives. And it's really important to ask ourselves that is our health system is just prolonging that. And that is the whole basis of bringing the concept, because we are living longer, we are living way longer, and if we really want to invest our resources in the best possible way, we would like to see how we can measure that, are we getting any benefit out of what we are investing. So the concept of the quality of life came from disease specifically, where there is no uh, really edge on survival. For example, some of the chronic diseases, people will continue living, and the only thing that will really matter is they will have either improve or very decrease or decline quality of life. For example, asthmatic patient, if you don't treat them, they'll linger on for a long time, but their quality of life will be very bad, because they will have breathing difficulty, they won't be able to function. Um, Same goes with palliation, cancer treatment. Once cancer treatment has resulted in a decision that there is no uh, point in continuing it. The most important part of patient care after that is in the palliative care, is to keep up the quality of life as much as you can. Make sure that they are having a much dignified departure from the world, if we say in those terms. So quality of life really matters in that term. Um, Another problem with uh, with the way things are is, we really in some time we can really not explain that what is the quality of, so we cannot really express that what is the benefit. So like say, even if you decreases frequent exacerbation, you decreases the hospital admission, sometimes you really don't realize that what is the outcome in it. So yes, you have saved some resources, so you can better use those resources. That's a benefit to um, hospital or healthcare organization or government, but what is the benefit to an individual patients? And that's why it is really important to understand that there needs to be benefit to individual patients, and that benefit to individual patients can come in form of improved quality of life. Um, it also helps patients to choose medicines, that medicine A versus medicine B may need to be taken more frequently, or maybe slightly expensive, but it will improve your quality of life in a long term. So it's really important in most situations where we like to measure the quality of life, but how do we measure it? So we um, measure it. So this is slightly complicated, but let me try to break it down as easily as I can. So quality of life is a very subjective term, right? You see, so in the quality of life in its broader term have two components, which is like a measurement of a health state, whatever health state a person is at that particular time, um, and then measurement of a preference for each of those health state. So for example, what is health state? So a health state is, I'm healthy, um, or I'm dead, right? So there is usually two choices between either you are healthy or either you are dead. Either you are 100% healthy, there's nothing wrong with you, you're fine, you are full of potential, you can do whatever you want, or you are simply dead, which is zero. But usually, all of us at a given time, until we are dead, we are between 0 and 1. Um, some people are at 1, like even when you ask people different questions and try to measure if they are truly at 1, a lot of the time you see people are not truly at 1, they are like 0.99 or 0.98. But the bottom line is that we are between perfect life and death, and there's one point where we are. So the quality of life, try to pick up the value of where we are in terms of 0 to 1. And usually what happens is, in a discrete choice experiment, or is in a form of another technique called a standard gamble, you give people different state of life, and you say, okay, let's see, I give you, and I'll try to explain it in as simplest term as possible. Let me see if it is not on the, so yes, I haven't describe it a bit later. So let me just focus on how do we come up with this value. So we give people a choice. We tell them that, look, if I give you 5 years of perfect health, like you are at 1, 5 year of perfect health. Now, if I give you an additional year, say I give you 6 years of um, life but not perfect health, I'll give you a given state, and they create a state, they describe that state, that you may have slight discomfort in your right leg or slight discomfort on your left leg, or another state, pain and this and that. And then they basically give you an option whether you can have 5 years of perfect health or you have 6 years of, say, a compromised health, then 7, then 8. So there's a point where people will say that, no, I don't want more life if my quality of life is, say, below zero point 0.7 or zero point 0.6 or zero point 0.5, and that's different for everyone. So that's the origin. So we try to measure that at what stage people will stop taking more quantity of life versus quality of life. Uh, Now, again, it's very complicated procedure. I've just explained you in the simplest short terms so that you can relate it to how we measure it. So we measure quality of life using direct or indirect measure. Direct is, we tell people, okay, what is your quality of life today between 0 to 1? So you can just say, okay, this is my quality of life. You can have disease specific quality of life. You have asthma measure, you have dialysis measure, you have indirectly in terms of generic questionnaire which are not specific to a particular disease, and you can just measure it based on valid instrument. For example, EQ5D that we are going to discuss further is the most commonly used quality of life tool, and is actually the one that preferred by NICE. So this is how it looked like. So as you can see, is EQ5D3L, but there's another one with 5L now. So as you can see that they have these option. I have no problem in walking about. I have some problem. I'm confined to bed, and you can choose different scores. So what will happen in this case? It will be like, so it will be 3, 3, 2, 1, and 2. So you will have this one state. So as you can see, there are like 245 possible health states, and they have been used. Um, so there's like actual UK public data available about these health states, and based on that health state, they have come up with the specific values. So once you fill up these one, you will have like you won't have a score, you will have the number. So you see is so 3 2 1 3 2 1 3. So you can either choose no problem and then you have a score of 3. Sorry, so other way around. So if you choose this one, so 1 2 3 1 2 3 1 2 3. So basically you can pick up any choice between these choices, and at the end of the day you are going to have a code. So for example, 1 1 2 3 2, 1 1 2 3 2, and then somebody will else use another choices and they'll have a different code, but at the end you will have these states. So as you can see, the health states where you have no problem at all, 1 1 1 1 1, and we believe that the quality of life of this is 1. So then you have 1 1 2 2 1, and as you can see, so for example, it doesn't matter if there's equal one or different two. For example, this one has 2 1, this one has 2 1, and have 1 2, and then another 2 and 3. So if you think about it, this one has 1 3, 2 2, and 2 1, and this one has exactly same but different domains. And you can see because of that, one is ranked as quality of life of 0.329, while the other one is ranked as the quality of life is 0.22. So you're going to get a value based on filling out the survey, and that value will be your quality of life. And then you multiply it with the survival. For example, I'll show you. And just to reinforce the point that as you can see that some state people consider is worse than that. So in UK database for this code, which is confined to bed, unable to wash or dress, unable to perform usual activity, extreme pain, moderately anxious or depressed. The person rating this or the group of people rating this state consider that it is below 0, which is negative value. So the QALY is basically an acronym of quality adjusted life year. And what we do, we have the survival data, which we know that people are going to survive 7 years or 10 years or 5 years on this treatment. And then we have the quality of life utility score, which is this. So as you can see, 0.76, 0.516. So what you do is you multiply the total survival with that utility score and it gives you QALY. So for example, let's assume that if we don't do any operation on a particular health state, then the utility value is zero point 0.5 and the current life expectancy is 2 years and the QALY is 2 times 0.51. So one quality adjusted life year is the QALY if we don't do anything. If we do the operation, the health state improved to zero point 0.9. So after operation, a person is able to function and is a score on quality of life measure improved from zero point 0.5 to zero point 0.9. And then because it also increases the life expectancy of 5 years, so now we multiply 5 by zero point 0.9 and we find 4.5. His baseline QALY was 1, his new QALY is 4.5. So we believe that the treatment of operation will give a 3.5 QALYs. So then we divide the cost of whatever the operation is by 3.5 and we'll get the um, dollar value or a pound value that will give one quality adjusted life year. And that's how we start comparing the options. So then we compare with medicine versus operation, no operation, just medicine, most likely this patient must be on some sort of medicine in terms of pain or whatever the treatment problem is. So no operation means that they are considering that option, that medical management of the treatment of this patient. So as you can say, Collie gain, Collie loss, and sometime you have intervention that will no intervention or intervention that can result in quality lost. Sometime we have intervention that can actually result in quality gain, and this is how we compare it. At the end of the day, we should have a cost utility ratio. We can use it for cost effectiveness, cost benefit, anything. So here if we replace number of quality produced by intervention A by number of admission prevented by A versus B, this has become cost effectiveness. If you replace it with money, become cost benefit. If you put quality, it become cost utility or cost effectiveness ratio. So we are going to have a cost effectiveness ratio of our treatment, and it is the incremental cost effectiveness ratio, means this is the cost of producing one collie that we are going to apply in our evaluation. At the end of the day, we are going to then have these four boxes. um, Top left, we'll discard it because it's more costly, less effective. Bottom one, less costly, less effective. Sometime we consider it if it's feasible and the effectiveness is acceptable. Less costly, more effective, we'll use it. So the pink one we discard it. Southeast we take it. We don't do anything because that's really good for us. More costly, more effective. This is the time where we need some decisions, and depending upon the impact of gain, depending upon the availability of resources, we make decision or the government make decision, because the job of health economics is just to give the science to the decision maker, and then they need to make a call on that. Now, health economic model, I've explained you enough about that, so I'm not going to go into detail. Same goes with sensitivity analysis and discounting. I've explained you it's not directly relevant to you, but it's good to know. And that explanation is more than enough. Now, how to evaluate an economic evaluation is really important. So when you're reading the paper about economic evaluation, when you're looking at an economic evaluation, considering it to be used in your practice, you would like to see whether it is a good one or a bad one. So four things that you need to understand. Perspective needs to be very clear. It simply spell out who it was measured for. So what, excuse me, what, whether it was a public perspective, societal perspective, payer perspective, because the costing depends on that. It's important to know that you won't be able to have skills to assess the impact of costing and how accurate all the costings were, but you should be able to know the detail of the costing and the objective analysis that they are presenting. So if they are presenting in detail how they cost it, and it's crystal clear, it's transparent, that's a good economic evaluation, that you know that they have done enough in terms of costing. Make sure that they are talking about marginal cost, make sure they are talking about direct indirect costs, make sure they are talking about some sort of standard reference for costing in order for it to be a good study. Benefits should be reproducible, should be tangible, you can see them, you can um, make a logical case that yes, these are the benefit worth considering. They are relevant. So things that you are looking at, if benefits are not relevant to your practice, it won't be useful to you in terms of the research paper. So it's important that you see that they are measuring the benefit that you are interested in. And there is some sort of either acknowledgement of discounting or sensitivity analysis or actual sensitivity or discounting analysis, because if they are not doing it, then it means that they have not done the best practice. But if they are providing the logic for it, or they are providing a caution for it, then all you need to do is see if the assumptions that they are making are similar to your assumption or similar to your situations. In that case, you can use it. Most importantly, don't just pick up the first economic study that is relevant to what you are looking for, but make sure that you are looking it from different angle to see if it is a good study, but it is also relevant to you, and the question that they are answering is the question that you are looking. Now, practical example of health economics, as you can see, um, we have chronic disease, as I told you, the most common one. Excuse me. And when we are dealing with chronic diseases, there's so many aspects of chronic diseases that require attention. Focusing on a specific aspect will be the most appropriate one, because then you can design an economic question, economic analysis about it. I have chosen the choice of asthma. So asthma, very common chronic health condition, and very common question is, there's a lot of asthma inhalers, which one is better? So there was a study about looking at the impact of two major brand, and see whether one brand or one strategy is better than another. So we will do that as an example. I won't go into details of it. I'll make it available, and I'm going through in reasonable outline of that. So there's the paper that will be available to you. Uh, so as you can see, it's about the cost effectiveness of two regimen. One is smart or mart regimen, where we use inhaler, same inhaler as preventer as well as reliever. Means you can use the same inhaler for your emergency shortness of breath as well as your maintenance treatment for asthma, while the other one is Seretide, where you use Seretide as a long-acting renewal treatment, and you use salbutamol or Ventolin as and when needed. So it was a cost effectiveness study. Um, it was done prospectively in a randomized 12-month study. So they did side by side. So it's basically economic evaluation alongside clinical trial. It's increasingly popular study, increasingly popular strategy, where do you do economic analysis while you are doing the clinical trial itself. And basically they look at what is the cost effectiveness of these two regimen, and I think they should have look at the resources. So let's see. The cost will be the cost of the treatment. So data were pooled and unit cost from Italy, France. So resource utilization data, so they actually did more cost, so they did not uh, yeah, so basically they look at estimate for direct and total cost per patient per year. So they look at whatever the cost is to the patient, as well as they also measure the cost of any exacerbation of asthma, because that is part of the cost. Um, when you treat patients, in terms of benefit, they look at so resource use, days in hospital, emergency room visit, specialist or primary care physician visit, other healthcare provider consult, indirect costs including the number of days when the patient on their care was unable to attend their normal daily activities. The study assume a European societal perspective. So you see, there's enough detail in it. Um, and then they put the results on. So if you think about this, it's reasonably well conducted study. Um, So you need to go into details. So they look at the patient treatment. You need to look at the treatment allocation. You need to see if the baseline characteristics are similar. You also need to see if the patients were treated equally. So um, all the validity and quality assessment of the trial itself. Um, and then you look at how they define clinical effectiveness. So you look all the definition, direct and indirect cost. So you look at the detail of the cost, seems like reasonable detailed cost. Um, they also have unit cost, marginal cost. So basically they come up with the unit cost of each treatment option. They have different treatment options. They actually talk about how they calculate the economic analysis, how they do incremental cost effectiveness ratio. So reasonable statistical analysis was there. Uh, so they so bootstrapping is another technique. We won't go into detail, but they actually look at different aspects. So they basically did not rely on their own data, but they try to replicate the same data with different variations to see if there's any difference. And for this, they use 10,000 bootstrap sample. So each unique case also generates. So based on your case, they also generate 10,000 more patient scenarios to see if there's any difference, and they consider that as the replacement of individual data. So you see bootstrap were drawn with replacement from individual data. Resource cost utilization is a technique where they increase their sample size not just to inflate the benefit, but or not to inflate the benefit at all, rather to see if the assumptions or the data that they have is reliable enough. Um, which is an acceptable technique. So if they are using a reference to an acceptable technique is acceptable in health economics. Um, we also would like to see if we have sensitivity analysis. So they talk about cost effectiveness analysis, but they did not talk about sensitivity analysis. And so it's important for you to look at that why they did not find that, and if they did not do discounting or if they did not do sensitivity analysis, then it's a good thing or it's a bad thing. So you need to look at it. I think the obvious reason for not doing discounting is quite specific because this was less than a year comparison. So it's for 12-month comparison. So you basically don't need discounting for more than or less than or up to a year. There's no change in inflation. It's finishing in 1 year. Um, but in terms of sensitivity analysis, have a look at it if they did it or not. My understanding is they haven't done it. The good thing is that they have done the four different countries chart. So if you can see that they have done the UK, French, Germany, and there was so German, UK, French, and Italian. So they look at four different economies, and you can see that the there's a significant difference between all of these. The most neater one is the D, which is German. As you can see, the most neater is cost effectiveness plan. As you can see, is either uh, top right. It's way into. So this is the cost effectiveness plane. Sorry. As you can see that this is the area that we talk about that is cheaper and more effective. So it's a no-brainer on these one. Here and here is more of like cost effective one. So let's see. So if you look at A and B, French unit costs, They've discussed it in detail. You see, this indicate increased effectiveness of Symbicort, significantly lower cost than Seretide. So definitely, you can see that this and this can easily be considered as the preferred option, C and D. Um, so have a look at this, and this will give you some understanding of what the cost effectiveness analysis look like in actual study. And after that, I think I'll just cover like few minutes on how you can demonstrate in your portfolio to meet the requirement of applying the principles of health economics is make sure that you're not just looking at uh, um, just not talking about the cost of the medicine. You consider it as example where the treatment might be expensive, but demonstrate the real value of that money. So um, for example, if you're using some of the DOAX in one of your portfolio or one of your example of prescribing encounter, then think about it that those DOAX often are expensive, but they have less monitoring and have less bleeding side effects. So overall, they become cost effective. So that's one example. Use of various asthma inhalers. If you are having generic substitution in your practice, is very obvious thing because generics are like cost minimization type of analysis, excuse me. So if you're using generic, then definitely cost minimization will apply there. So just be considerate when you are applying an example of health economics or considering cost effectiveness of medicine, and in that way you should be able to demonstrate the cost effectiveness analysis. Okay, thank you very much.